Welcome to the Cincinnati Children's Heritage Video Series. These videos are a project of the Medical Staff Historical Committee. I'm Dr. Elaine Billmeyer. I'm a retired community pediatrician, and I'm a member of the Historical Committee. And with me is Bea Katz. Bea is a former long-term employee of marketing and communications at Children's and was the author of a photo history of Cincinnati Children's that was published on the occasion of its 125th anniversary. Today our topic is the ongoing history of the Pediatric Surgery Division at Cincinnati Children's, and we have two surgeon-in-chiefs with us today. Dr. Moritz Ziegler, who was surgeon-in-chief 1989 through most of the 90s, and Dr. Dan Allmen, who did his training around that same time and has now come back to take over as surgeon-in-chief. So welcome to both of you. Thank you for coming. Let's just start. Give us a little thumbnail biography. Tell us how you happened to come to Children's, and then we'll go from there.
Well, I'm a Michigander, so the first trader thing I did is I moved to Ohio, but I went to Ohio to undergraduate school and then medical school in Ann Arbor. And then I went to the University of Pennsylvania to train at Children's Hospital and the hospital of the University of Pennsylvania. And I went really because I knew that C. Everett Koop was the surgeon-in-chief at Children's in Philadelphia, and I had read an article that he had written, of all things, in Reader's Digest. And the article was entitled, "What I Tell the Parents of Dying Children." It was sort of a grabbing kind of article, and I read that, and I honestly said to myself as a junior medical student, I think this is what I would like to do. So it prompted me to go to CHOP, and I trained with Dr. Koop, and then I became a faculty member there. And Dr. Koop retired and went to Washington as a Surgeon General of the United States Public Health Service, and he was replaced at CHOP by James O'Neill, who had been the chief of surgery, children's surgery at Vanderbilt. And Jim came and was a terrific leader, really, and a mentor to me, and I started to look for leadership positions, and I found that Dr. Martin was retiring from Cincinnati Children's, and his reputation as a leader of the surgical service here was extremely strong. So that's why I ended up here through the recruiting process, basically.
Dan, you want to take
Sure.
up?
So yeah, absolutely. I'm an East Coaster, so I grew up in Philadelphia, where we never personally overlapped, but we did overlap at CHOP a little bit. But I grew up in Philadelphia after being born in Boston, but grew up in Philadelphia, and my college education was in Northwest Massachusetts at Williams College, and I was going to be a private practice, family practice doc, and I went to the University of Vermont for medical school, where I really got intrigued with surgery. And one of the things that happened there is I rotated on pediatric surgery, and there was only one resident on the service, and he had the good grace to get married during my rotation, so I got a field promotion, and it was just a phenomenal experience that really had a huge impact on me in terms of our ability to impact patients' lives, and when you do that for a child, it just is incredibly rewarding. So I started to look for surgical residencies, and somehow, and I still don't know how it happened, I interviewed here in Cincinnati at the general surgery program here at the University of Cincinnati, and I honestly, to this day, I have no idea how it got on my sort of list of places to apply, but when I came here, certainly one of the reasons was I wanted to have access to Children's Hospital as wanting a future career in pediatric surgery. And when I came here, it just was something that felt right, and I even brought my wife back, and she just wanted to be out of Vermont because it was too cold. And when we came back, the plane was landing, and I'm looking down, and I can't see the ground. And I get down, and it's covered with snow. And I thought, oh my goodness, this is bad timing.
But not Vermont.
But right. But so we came here and spent did my 5-year general surgery training here, along with 2 years of research. And during that time, I did the ECMO fellowship at Children's, and
Right, okay.
worked just about the time that Dr. Ziegler moved here and took over, and spent some time working with Fred Reichman, and then was incredibly fortunate to be able to match at Children's for my pediatric surgical training. So it was a wonderful turn of events for me to be able to spend time at both of these institutions.
So going back now, when you both were here then in the late 80s, 90s, what was the surgical division like back then? How big was it? What were you doing? What weren't you doing?
Well, the things that Dr. Martin had focused on was really clinical excellence, and his program clinically was just that. It was excellent, and the likes of Fred Reichman, who Dan mentioned, is a spectacular surgeon, as was Dr. Martin. And then the other faculty that were here were Dick Stevenson and Joe Cox. And so what we wanted to do, or sort of programmatically, was to develop the areas that had not been developed. And the first one was a trauma program. And so I had known Vic Garcia from medical school days onward, and he trained with us at CHOP. And so I knew Vic very well, and quite frankly, very much wanted to recruit him here for both his professional skills as well as his cultural background, an African-American surgeon coming to Cincinnati. And then after that, we fortunately, the likes of Dan were commonplace amongst our trainees. We just had a run of really spectacular young people. And some of those Lester had recruited, like Alan Flake, I inherited, so to speak, when I first came, and Brad Warner, our second star in a row, and Brad then was recruited by us to stay here and join the faculty. And that made us able to penetrate into really significant research. And Brad became a funded NIH investigator and has continued his funding and his stars-like quality work ever since. And then Brad went on to train Mike Helmrath, and Mike and Dan have been associated before, and then they both came here. So it's sort of like a small club family.
Sure,
And
yeah.
we sort of profited by the skill set of these young people.
Anything you want to add to?
No, it was a great time to train here.
In the olden days.
The old days.
that
I
long
think
ago.
one of the things I frequently say now to some of the younger folks at Children's is that, just from a matter of perspective, I have no idea what the actual number is, but my guess is that when I trained here, there were probably 4,000 employees, and now there are 13,000 employees. So the incredible expansion that the institution has experienced in the last 15 or 20 years is really remarkable. Back when I trained, it was before any of the new buildings existed, and you could there was you could stand in the middle in the little control room in the middle of the operating room, and you could see into all the different ORs. And, now we have this very large, very sophisticated place, but it was a different institution then, and I was fortunate enough to be present during the sort of transition at the beginning of that, with people like Dr. Ziegler driving programmatic development in surgery.
So I think we'll come back to many of the topics that you've both just raised, but we want to step back a little bit. When you came, Dr. Ziegler, you were stepping into Lester Martin's role, and he was considered and is still considered a legend. So what was that like? Was it difficult to step into his shoes, and how did your approach differ from his?
Well, I'll have to think about the second question in a minute. But, we celebrated Lester's career here with what we call a Festschrift. And in that celebration, I thought I had to add some words as well. So in addition to his trainees who dominated the program, I put myself, quite frankly, on the program. But the title of my talk was Shoes. Because how do you fill a guy's shoes with that kind of background? And just to give you a bird's eye view of the history of pediatric surgery, the founding father is generally attributed to be William Ladd of Boston. And then Ladd had the foresight to recruit a guy by the name of Robert Gross. And Gross was a legend. He did the first cardiac procedure in a child. He did a ductus ligation in 1938 or something like that. Gross then trained every leader in American pediatric surgery, literally everyone. And that included Lester Martin to Cincinnati, Bill Clatworthy to Columbus, C. Everett Koop to Philadelphia, and so on and so forth. And that is how the field sort of grew up. And Lester was the guy in Cincinnati, and he just had clinical skill set that was above the majority. And he focused on certain things like Hirschsprung's disease, and pulled through procedures for Hirschsprung's and really defined the technique that allowed that operation to be such a success.
And they did some of the first transplants.
Yes,
then,
that's
too.
right. I
mean,
think
it's
Lester
kinda-
came in 1963 or 4, right? And it was a decade earlier that the first human kidney transplant was 1954 in Boston, and it was a related living transplant, and I know that Lester continued to do allografts.
Yeah.
I think he did the first kidney
Transplant.
transplant in Ohio.
Oh.
Yeah. So was that intimidating to step into his?
Well, it was intimidating, but I had spent 12 years as a junior faculty person at CHOP, and I guess arrogantly thought I was capable of following him. But I mean, the thing that I had to learn from him was the social side of dealing with a department of children's surgery in a place where it was the only. Whereas in Philadelphia, when we were there, you know, it was Children's of Philadelphia, but there was St. Christopher's, there was AI DuPont. You know, those were all competitors.
Yeah, this is a very, very unique
Yeah.
situation in that regard. Yeah.
It really
So,
was unique.
Yeah,
yes.
yeah. So you do bear the distinction of being the first pediatric surgical chief employed by Children's as opposed to the university, right? You want to tell us how
Well,
every surgeon I talk to and I say Roy Ziegler, they say, oh, and you know, he was the first. So.
Well, it is a somewhat unusual thing. I mean, every place has a model, and I've actually been, as you know, at CHOP in Cincinnati and Boston and Denver, and I must say there are 4 different models. But what the case was in Philadelphia with a personality as strong as Dr. Koop's was that he was not only the chief of the division of pediatrics general surgery or general and thoracic surgery, but he was the surgeon-in-chief of all of the surgical services at Children's of Philadelphia. And I must say, I thought that that was the right model and the ideal model. The situation in Cincinnati was Dr. Martin, with all of his worldwide reputation, was the head of pediatric surgery, but by governance, I guess, you would say, the chairman of surgery at the University of Cincinnati was the surgeon-in-chief of Children's Hospital. As I was looking at the position, I really must say I wasn't intending in any way, shape, or form to modify what I grew up under. I thought that was the right model, and I wanted to do that. So I asked Bill Schubert during the recruiting process if he intended to change, or would he intend to change, the titles of who was chief of surgery of all the Children's Hospital, from the chairman at the university to the new surgeon-in-chief here. And we talked long about it, and I think that I convinced Bill somehow that that's what we should do. And I must say, forever, Bill Schubert will be a hero in my mind, because I thought he was absolutely a wonderful president, chair of pediatrics, head of the research foundation when I was here, because what he said to you is what it was going to be. And he was a man sometimes slow at making decisions, which drove me as a surgeon crazy. But when he decided, that was the word. And so my story, as I think I've alluded to you, is we went to dinner at sort of the final phase of the recruiting process. Bill Schubert, Joe Fisher, who was chairman at the university, and myself at the Maisonette restaurant then. And it had those sort of curled
those booths.
Right. Booths. I was in the middle, and Bill and Joe on either side. And sometime during the dinner, I don't know why it was then, but Bill said, "Now, Joe, we've been talking, and we're going to make a change. We're going to offer Maury the position of chief of pediatric surgery and surgeon-in-chief of the Children's Hospital, and you will no longer be the surgeon-in-chief." At which time I went under the table. I didn't. I mean, in all due respect to Dr. Fisher, that was sort of a sudden, revelation, and I think his feelings were hurt, but that's the way it was presented to him, and that's the way Children's Hospital, in truth, recruited me here. And I don't think it. Well, from my perspective, I thought it worked fine. And then what happened is that Dr. Martin was in a private practice, in a corporate entity, separate from the School of Medicine and the Department of Surgery, but Joe was the surgeon-in-chief. So what happened over time, and it didn't happen immediately, we became a new entity employed by the Children's Hospital.
Do you think that helped with recruitment? That arrangement necessarily, or?
Well, I let Dan say his feelings about it, but I would tell you this, that of the various models, and I've worked in every model known to man, I felt at the time that it was the very best model that could have happened. Now, I say that in part because Bill was my president and chief executive officer to whom I reported, and I had great admiration for him.
Do you agree?
What do you think,
Yeah,
Dan?
absolutely. I haven't. I've spent time at CHOP and spent time at the University of North Carolina and spent time here. And as Maury has indicated, that's 3 different models. And
Right.
I had the experience. Maury alluded to Mike Helmrath, who's one of our surgical researchers, just phenomenal research. And I had the opportunity to recruit him to the University of North Carolina, and then I had the opportunity to recruit him here. And the model here makes that process much, much easier, to your question. And it's when you have a standard academic healthcare system that has a hospital and has a faculty group and has the medical school, everybody thinks everything's a great idea until it comes time to pay for it. And then it's like this.
Yes,
Whereas at Children's, it's essentially all one bucket, and it's much easier to get somebody the resources they need to be successful, and that's a huge difference. My time in Chapel Hill, which was wonderful, it's a great institution, but the approach was, what is the minimum amount we can invest in somebody and get them to come here, as opposed to the approach of what is it that this person needs to be successful, and let's get him what they need to be, or her what they need to be successful. It's just a different mindset, and I think it's facilitated by the type of structure that exists here.
So we've talked a little bit about what the hospital was like when you arrived, and there have been obviously many, many changes. As well as many changes in in the practice of pediatric surgery. So we wanted to explore that a little bit with you. What kinds of changes have you seen in the organization and in the field?
Well, the organizationally, the thing I would say first is that, and Dan will echo this, I would love to hear what he feels about the current situation, but the surgeon-in-chief therefore represents not only pediatric surgery, but represents otolaryngology, orthopedics, et cetera, et cetera. So we have to work as a team. And so one of the huge really changes, I think, in surgery anyway, in my era, was the changeover from the old surgical professor, you know, the ruler with the iron fist, to the team approach of medicine. It's just the way it is. It's that way in the operating room. You can't do an operation without an anesthesiologist and a nurse and a team of people who have the same mindset of working towards the safe end of the child's operation. So that was one of the big things for my responsibility anyway. And then what happened is the evolution of surgery. One of the nice things we had in Cincinnati was, oh Dan, I just forgot the developmental place out in Blue Ash, Ethicon into surgery.
Ethicon, yeah.
Ethicon into surgery, which fortunately joined forces with us and supported research in the field of minimally invasive surgery. But I'm
Say Ethicon, don't they
taking
make
that.
suture?
Yeah.
Well, they make lots of
That's
of stuff.
my
They make
a lot of
instruments as
things.
well.
They make instruments. Okay.
And
okay.
treat and teach people
Yeah.
how to use it.
They had
Yeah.
a laboratory there,
Yes.
didn't they? Yes.
A training
Yeah.
ground.
Yeah.
They have
And
a
then
very nice
minimally
facility there.
invasive surgery
Yeah,
became a
tell
thing,
us
and then
about-
young people like Dan
Yeah.
was ready to take off with it.
Yeah. Tell us more about that.
Yeah.
No, it's, I think having access to things like Ethicon, obviously one of the, surgery continues to evolve as technology evolves, and surgery is all of medicine is, but certainly surgery is a very technology-heavy practice of medicine. And so as that has evolved, it's being in a place like Children's where you have access to things like Ethicon and you have resources. And but I want to go back for a minute because I think to me is one of the most important things about Children's, and is something that I will call out every time I interview somebody for a new job or speak with the trainees, and that is the culture of collaboration that exists at Children's. And
That was one of our questions.
Yeah.
yeah, well, I think Maury alluded to the surgical programs working together, and that extends beyond the Department of Surgery. It's not just divisions of surgery that work together, it's divisions within pediatrics and surgery, it's research and clinicians. And as the quality and safety movement took over, I think that was extended to everybody at Children's, and everybody has a voice, and that the culture is that everybody should express, should have an opportunity to be part of the team. And I think it is one of our greatest strengths. It's one of our differentiators, and it allows things to happen. The evolution of that in terms of technology is things like the program we've just recently started in image-guided surgery, which is a combined program with radiology and surgery, working in a brand new fancy hybrid OR room that has radiology equipment and is in a surgical OR. And that doesn't happen in other places. It just doesn't. And it's the culture here that
Children's is ahead of
facilitates that. Yep. And I think that's the future of medicine. Traditionally it's been very siloed, but as we learn that outcomes can be improved by working together, that's going to, and as medicine becomes more and more dictated by outcomes as opposed to what your name is or anything else, that's going to be really important. So I think it gives us a leg up at Children's because that's part of our DNA already.
So maybe this is a little out of order, but of the sequence of questions that we have. But since you've mentioned improvement work, one of the questions, I know both of you have been involved in surgical quality improvement. So we thought maybe you could talk about the impact of that in your careers and on this institution.
Well, I'll go first, I guess. In my own personal life, it really has become the goal or the trajectory, I guess I'll call it, in that when I was a faculty person here, I think we began to start to talk about those kind of things. And then Bill Schubert stepped down, Jim Anderson came, and Jim was highly motivated to talk about outcomes and to develop a center that would study outcomes with Uma Kodagal and others here at Children's. And it so happened that when I went on to Boston, I guess it would be, and then Denver, I was the chairperson or the president of the American Pediatric Surgical Association for a year. And everyone sort of sequentially had taken on a project. And in my year before I was president, pre-year, we did a strategic plan. And in that plan, we looked at developing a pediatric surgical quality improvement program, the NSQIP/pediatric. And that was done in collaboration with our American Association, which I was from, and the American College of Surgeons, who had done that in adults. And, you know, let me choose to digress for a minute just to give you a little history about the background of this. But in 1910-ish, this guy was a surgeon at Mass General. And in Boston, he was a Bostonian trained surgeon. And he suggested to the surgical community in Boston that every hospital should know the outcomes of every single patient. And his work was, to the Boston elite, it was controversial to say the least, and they kicked him out of Boston. So he returned to Boston some years later, and he bought a hospital, and he named it the End Results Hospital. That's what it was named after.
The end results.
And so I only say that because that was 1910-ish, and the American College of Surgeons National Surgery Quality Improvement Program didn't come until a little after 2000. And so it's almost a 100-year gap. And that program was focused on outcomes, and then the pediatric surgical program that we developed was also focused on outcomes. And, you know, it started very small, but now the numbers are hundreds of thousands of patients have been enrolled, and we know the absolute outcomes on those patients. And it has allowed things like, I think Dan's team speaks to infection control and other things like that.
Yeah, I was going to say, what specific things are
so
you
I'll
looking
let
at?
So Maury's obviously been involved very much on a national level, but on a much more personal level. When I came here, one of the things that when I came back as faculty, one of the things that attracted me was the quality improvement work. I had seen Uma Kodagal speak at the University of North Carolina, and I thought, well, I know about quality improvement. And when I got here, I realized I didn't know anything about quality improvement. But one of the great things is the ability to learn that here in formal training, and the fact that that has been done across the organization gives everybody a common vocabulary and really allows for this work to be done in a much more sophisticated way at the Children's Hospital. And so now we have extensive quality improvement programs. We look at surgical infections, we look at outcomes, we look at a whole dashboard of different things.
Is the hold point, is that part of that? Or?
Sure, that was one of the things in surgery, and being Cincinnati, we couldn't be satisfied with just doing a hold point like everybody else does. We actually have 3 hold points. So one before anesthesia, one before surgery, and one after the procedure to say, here's what we did and here's what the plan is. So, and that's the kind of thing that when the regulators come, federal regulators, they look at that and say, wow, this is best practice. You know, this should be done by other people.
Now, one of the other new things that you knew back then was a new OR. You were involved
Yes, that
in
was-
design
And
tell us about it.
subsequent, Dan
Yeah.
can bring us up to the
Yeah.
current speed, but
Yeah.
when I was here, we decided to build the tower building.
Mm-hmm.
And that, by the way,
Just for vocabulary's sake, it was called Hospital Tower when it opened, but it's now Location B.
B.
Yeah,
okay.
but you
Well,
call it the tower. That's
Yeah,
okay.
That's what
It's
I
still
did.
a tower.
And I must say,
Yeah.
that was a really first example of team. And it required the presence of a lot of people to commit time to planning, because we wanted to do the operating room of the future, so to speak.
I was going to say, this wasn't driven just by need for more space.
No.
You needed
We
function.
wanted to be really
Yeah.
the best that it could be.
Yeah.
I guess I'll say it that way.
Mhm.
And we got into an unusual structural model of putting anesthesia rooms adjacent to each OR, so that it would be a pre-induction kind of place for the patient to go, just to improve flow through the operating room. That has been or has not been successful, and I'll let Dan speak to that.
Okay.
But you know, the bottom line was we all of the surgical faculty owned the planning of the process, as did the nurses from the OR, as did the anesthesiology team. And in fact, there were some surgeons, like
Really?
chiefs of plastic surgery,
I knew you were going to talk about it.
who said, "Who planned this OR?" And I said,
You
"You
did."
did, David." And he was an integral part of planning, but as was everyone.
Yeah. Yeah.
And it really, I think, was a spectacular opportunity to move into that operating room and have all of the pleasantries of what it was like and what we had anticipated it would be like. Now, Dan is talking about new ORs like the
Yeah.
radiology one, and I think further expansion, I'm sure.
Yes, yes.
You're still in the same location.
We are still in the same
Okay.
Are there
location.
plans
Yeah.
to move it into the new building under construction now?
There are not plans to move it. It was not part of the new critical care tower, our new tower. The critical care tower does not include operating rooms. There, where that building connects, which on the third floor connects directly to the perioperative space, there will be a couple of new ORs in the connector, and the reason for that is that the emergency department is moving to the new tower, and the helicopter pad will be on the top of the new tower, and we need to have a trauma OR on the same side of the building. So.
Okay.
So there's that. The other thing that will allow us to do is we have undertaken plans, very collaborative plans involving all sorts of people from all different disciplines to create a 10 to 15 year master plan for the space that we're in. And we will, the ORs of the future opened when I was a fellow. We're now going to create the ORs of the future again, with the new technologies and such. And it's not actually going to increase the number of operating rooms, but we do have a need for more space. And so with the new critical care tower, some of the cardiac rooms will move to the new critical care tower. We're going to have a brand new fetal center. And those cases will all come out of what is now the operating room complex. And we're going to develop some new space for the different paradigms of care that have become popular. For example, we will have procedure rooms that are for things that don't require an operating room, and we'll get patients through there faster, and better patient satisfaction, better care, better staff satisfaction, those sorts of things.
You said the induction rooms didn't work as
Well,
planned.
I would say they didn't work as totally
As
as
expected.
planned. The idea was you would have a flow through so efficient that you would have the next patient anesthetized and just
And then move
pushed into the operating room.
And parents were in that
yes,
room? I
yes.
mean,
Parents
that's the
were
feedback
allowed in.
I've,
Yeah.
and the parents loved that,
That's
of
exactly
course.
right. And they
Those-
did love that.
those
And
clearly did, yeah.
that part, I think, has worked fine. But it requires sort of the doubling of the size of the anesthesiology group. You know.
It takes a lot of space, and,
Yeah,
over the past 10 years, we've
Yeah.
really needed space. So all of that, much of that space has been mined to create new operating rooms or increase the size of operating rooms to make them more functional as the technologies have changed. In the new plan, there is a central induction area, so that will still exist, but with a little bit different model than having an induction room outside of each OR. And I just have to, I can't resist, but because I was a first-year fellow, we were in the old ORs with the little central core, and you could look into every room. My second year, we moved into the new building. And that was a relatively traumatic event.
I bet it was.
And I will never forget one of the really hardcore, tough as nails cardiac surgery nurses walking down the hall as we were doing this big move, and we all had T-shirts and pushing patients and this stuff. And she said, "Wow, I feel like I'm going to cry." And I thought, man, we are really in trouble.
Well,
If she would
it must have been disorienting.
But,
I mean, like,
yeah,
where's the scrub thing?
It's changed, and that's a big deal.
Now, you said with the plan of the future, you're going to have some trauma OR specific.
We will have specific rooms, a specific trauma room that's on the side of the building with the emergency room, and we have a trauma room now, but it kind of moves around depending on what's going on, and this will allow us a dedicated trauma space for the complex trauma patients.
And going back in time, you were saying, Dr. Ziegler, one of the things that you got started was a trauma program. You know, I mean, I remember as a resident, you know, right after the tax levy, you know, major trauma would come in. I mean, we didn't even have ER medicine. We'd be paging the surgeon, and there were only like 2 of them in the house, you know, and they were always in the OR. It's just kind of amazing.
Well,
people got through it. So.
It is another transition in medicine, and it's a transition particularly, I guess, in surgery, because the surgeon became the trauma doctor. But again, you know, the collaborative way that the program was developed, and I applaud Dr. Garcia for his insight to develop it that way, was that it had to be emergency medicine and surgery together.
Right.
And that's continued to this day under even changing leadership. So that, I think, has been the sound part of the plan.
So since we're talking about kind of program development and collaboration, can we talk a little bit about the development of collaborative clinical programs? Because I know surgery does a lot of collaboration with other divisions.
We have lots of collaborative programs. In fact, sitting on some of the growth committees and such now where we evaluate new programs, they're virtually all collaborative, and in some ways some of the requirements are that the programs are collaborative, because I think it's been widely recognized that that's how you really develop differentiated programs that provide the best care. And in surgery there are lots of examples of that. From trauma, our colorectal program is a classic program that involves not just colorectal surgery, but GYN and urology and GI, and I've already alluded to the image-guided surgery program. There's just example after example of programs that are groups of people working together who wouldn't necessarily and haven't historically necessarily worked together.
Is this a trend that's happening in other institutions, or is Cincinnati really ahead here?
I'd say there's a strong desire for this to happen in other institutions, but back to our discussion about structure, I think that Cincinnati Children's is somewhat uniquely constructed in a way from an administrative standpoint that really facilitates that kind of thing happening. It's just, it happens elsewhere, it's just a little bit easier to organize here.
How has the residency training program changed over the years? And
it's, you know, I
besides getting bigger.
Well, it's, you know, it's still the same size in the terms of the number of pediatric surgical residents that we train. When I was a fellow here, there was 1 each year, and there's still one accredited fellow each year. So that's a whole different topic, which Dr. Ziegler could wax poetic on. But the training program, you know, as with all trainees in medicine, there's a lot more rigor around the methods and the measurements of how training is done and what the outcomes are. And I think that we have been well positioned, and I've had the privilege of being the program director for the last 9 years until this past July, and we have our little wall of shame there with all the fellows who trained here, and it's really it's a great honor to be among that group because it's impressive.
Has the restriction in resident hours, has that impacted? Yes, of course it is. How has it impacted?
Yeah. Well, I'll tell you, one of the biggest
program.
ways it's impacted things is that as fellows in pediatric surgery, you're the two fellows, one senior and one junior, but we also have lots of other trainees, and many of those trainees are from the general surgery
Yeah.
programs who
Yeah.
have requirements. And many of the trainees are from non-general surgery subspecialties that we would get as interns or second year or third year, so the ENT
So
residents
ENT
and the
and
urology
yeah.
residents and such. Well, as work hours have been constrained, those programs have pulled those residents back in. So the model has changed now, where we use far more nurse practitioners to help us with the management of a big service. Our surgical service now is anywhere from 40 to 80 patients.
Yeah.
And
yeah.
it requires a lot of effort and a lot of people to care for them, and the acuity level is quite high. So without all the residents running around that we used to have, the model's changed to include nurse practitioners.
So would it be nice to have more fellows, or are we training an appropriate supply, or oversupply, undersupply? Is that you have any opinion
I
on
think
this?
that your question, Elaine, is a very good one, and it's a question that's at the forefront of children's surgery right now, and it seems to be a cyclical kind of question that arises. But the bottom line, in answer to your question, if you focus on those two residents, that is the ones that are going to be likely be American pediatric surgeons. We now know that the training program number has doubled. So instead of 24, they're not only 48, they're what, 54? 55.
Training programs
Training
around
programs
the-
across
yeah.
the country.
Yeah.
And if you look at what that has done to individual surgeon experience, it's dramatically dropped it.
Oh,
And so you
interesting.
can be a trainee graduate,
Interesting.
and fortunately you've just gone through a busy program like Cincinnati and have had great experience. But now as you go out and get your first job, and there are 6 others or 8 others or 10 others in your group, the likelihood of you getting the critical cases that you need to keep expertise on is minimal or
Interesting.
minimalized.
Yeah,
And so we're
interesting.
looking at a way to
Interesting.
control that. Dan can speak to it better than I, but the other question then is, what about looking at the world rather than the United
Yeah,
States?
yeah,
And so they do train individuals. Maybe you better explain that.
So because we have such wonderful clinical volume, that's an opportunity to train folks, but we don't necessarily need more accredited pediatric surgeons in the U.S.
Interesting.
That has provided us with the opportunity to provide subspecialty training to other folks, and we have a number of subspecialty fellowships, colorectal surgery, because we have such great colorectal volume, fetal surgery, which is a very unique specialty
Yeah,
that we
yeah.
happen to have a great program in. Vascular malformations, which is a big
Yeah.
program here.
Yeah.
And then another program that we started more recently is our international fellowship. And so it's giving people from literally all over the world an opportunity to come here for 2 years and spend 2 years doing pediatric surgery in a place like Cincinnati Children's, and then
Interesting.
to take those learnings back to their home country.
Interesting.
And almost
Yeah.
all of the surgical divisions have that. I know it's in urology and orthopedics and
pediatrics,
the interest in global surgery has exploded over the last 10 years, and this is one of the offshoots of that, which I think is very nice, because it's really providing people with the education on how
better
to care for
quality and
patients
all
and go
that,
back
yeah.
home and do that.
Fascinating. Yeah.
So another topic we wanted to bring up that we haven't really discussed yet is research. I know
Yes.
you began a research lab when you arrived, and you've been very involved in research. So can you tell us about surgical research in children's? Yeah.
Well, I think that before I came, there certainly had been some periodic and some focal areas of interest that were research, but mostly more for preparatory to a clinical procedure, you know, on a human. So that was my function at Children's in Philadelphia, to lead a surgical research program and to define some areas of focus. And so when I came, the program that I brought was a one on the study of the immunology of neuroblastoma. And it was a tumor then, as it is today, which has one of the most or least appealing cure rates
Yes,
because the
right.
outcomes haven't changed
Yeah.
dramatically. And so anyway, we had begun a program on that, and we had both American as well as international fellows in research to carry that forward. And then we had a sensational laboratory leader, Gajra Ira, who continues to work actually at Children's. And she was magnificent in taking these various international personalities and getting them all going in the same direction and really helped our program. But our program, I would have to honestly say, didn't really kick into the kind of gear it needed to kick into until Brad was trained and recruited. And you know, I'll say this in front of Dan because it was my error that restrained this or retarded this development a little bit, and that is that Brad was trying to be clinician, teacher, researcher, everything. And to do that, you have to have significant support. Like maybe a basic scientist, PhD, working with you in the laboratory.
Sure.
And I didn't get that at first because it was not the model that I was brought up in. And so Brad said to me one day, you know, you need to support my research in a stronger way. And he was right. And he recruited Chris Irwin, who to this day has remained with him. And it was shortly thereafter that the program went like that, and it was federally funded and really took off. And it was the start of something that is only further developed under Dan.
Yeah, I think that was a great history to really introduce meaningful, basic early research away from somewhat more upstream from clinical research and into the program here. And the evolution of that continues today, and I think it harkens back to our earlier discussion about collaboration, where we've referenced Mike Helmrath a couple of times, and Michael does research that's twice in the last year has been on the cover of Nature Medicine, which is, I mean, I can't even read the table of contents, and you know, this stuff, his research is on the cover. But one of the reasons it's on the cover is because of his partnership with the researchers in the Division of Developmental Pediatrics, or Developmental Biology in Pediatrics. And that collaboration is perfect because those guys are incredibly smart. They are interested in how a cell works, and Michael can take that then into a more translational, let's make something that we're actually going to be able to get into a patient someday. And they, the synergy there is, has allowed them to do really groundbreaking research that's, and that paradigm exists in lots of different places. Greg Tiao has had, you know, NIH-funded research for years, and that's through a capillary. He is interested in biliary atresia and the pathophysiology of biliary atresia, and that's through significant collaboration with Georgia Becerra in the GI department. So, again, people getting steps ahead by working together, and it's very strong.
Thing that you had mentioned earlier when we were talking about outcomes. So the whole area of outcomes research is sort of a new area relatively in the last decade or so, even though it has history that goes back to the early 1900s. But outcomes research for the clinician is a wonderful program, and UMA and others have led that here. And certainly the surgical group is very involved in that as well.
Anything we haven't covered here that you'd like to comment on?
Are we still on camera?
Yeah, we said
I had a thought that I don't even know if I've ever told you this story. This is not a good story to tell, but it happened. And we had residents here from different institutions, one of which was the Medical College of Ohio in Toledo, and we had a continued resident from there for a long time. And I remember when it came to a performance eval of one resident that the faculty en masse felt that he just didn't measure up. And so we returned an evaluation form to his program that described that. And we actually said we would recommend he not be advanced to the chief residency year, and that either have some remediation or maybe a career change.
Yeah.
So it was probably half a dozen years later when I lived maybe in Boston. Anyway, I was driving in Michigan, going to the lake in northern Michigan. And I heard this news report on the radio that in countryside of Michigan, a physician was just uncovered to be a non-physician. And I listened closely, and then I said to my wife, gosh, you know, this sounds like a story that I've participated in. And I called Julie Ludwig, who has been a long-standing executive assistant in surgery, and Julie immediately could find that record and our letter. And it turns out that this guy not only was finished in Toledo and became a licensed physician, was practicing in Michigan as a surgeon, and a hospital record room person recalled looking at his diploma on his resume, and it showed he was like St. Louis University. I'll say, I don't know if that was it. And then she said, but we have another person on the faculty who went to St. Louis University, and I don't remember their diploma looking like that. And she pulled it out and said, there it was a fake diploma. And can you believe that he got through our rotation, and he was a fourth-year resident then. And he went on to be a chief resident, licensed physician, and he never went to medical school. Scary.
Very scary.
Sounds like this
and then
could be a movie.
Yeah, exactly.
And you tried to do the right thing. I mean, I know that can be very, that can be a difficult process, and the lawyers get involved.
Yes,
but
for sure.
Well, it sounds like your instincts were right.
That part I felt good about, but I sure didn't feel good about the outcome.
Finding out what
what do you feel good about? Looking back over your career,
Yeah.
this is a nice time to assess. What are you most proud of? I know you've had some wonderful recognition and recently the Leonard Award.
I think, going back to this transition of medicine, and I think is real, from sort of the individual to the team sport, I think is an important, extremely important transition in medicine. And the only thing I would say is I think actually the culture of the city gets some of the credit. I mean, when you move from east to Midwest, it's a different transition than you move from Midwest to east. I can assure you it's different from personal experience. And so our Cincinnati culture is one of openness, friendship, dialogue. And as best explained by my wife, I guess, when she goes to the grocery store in Cincinnati, the person in front of her and back of her in line engage her in a conversation. Well, that, it doesn't happen in Philly, or it doesn't happen in Boston either. And so you just have to give credit where I guess credit is due. And I think it has helped Cincinnati Children's, especially with leadership like Bill Schubert and then Jim Anderson and then the current person who I don't really know. But it is a cultural place that has allowed Cincinnati Children's to really take advantage of that and become the great institution that it's become. I mean, world class.
Yeah, I would certainly echo those sentiments. I will tell my kids, my colleagues, anybody who will listen, that I have the best job in pediatric surgery, and I really believe that. And it's just an incredible opportunity and privilege to work at a place like this. And I truly believe that there are not a lot of other places that afford that opportunity, and so it's just it's an amazing way to extend what I felt in medical school when I thought, here I can change this kid's life, and now you have the opportunity to impact hundreds or thousands of lives. It's very rewarding.
Excellent, excellent. That sounds like a good closing
I think
statement
so.
to me. All right, well, thank you both for coming.
Thank you.
This has been enlightening. It's always enlightening. We go in different directions here.